today's program. I am Carrie Palardy with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and follow up on questions they do not have the opportunity to address. You'll receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter. Leanne Blackwell has over 30 years healthcare experience with a focus in ASC development and management. Her areas of expertise include direct patient care in multiple surgical services, clinical education, and training, including infection control and the ARN Peri-Op 101 program, and oversight of quality management programs. Leanne currently serves on the OR Manager Publication ASC Advisory Board and has presented and authored topics on patient care and survey and regulatory information impacting ASCs. Leanne currently serves as the Vice President of Clinical Services with Practice Partners in Healthcare, a Birmingham, Alabama-based ambulatory surgery center management and development company, and provides direct support to ASCs in multiple states in clinical best practices, oversight of quality programs, medical staff credentialing, and ASC accreditation and regulation survey readiness. Leanne is happy to share and network with all of you and asks that you not only take some important pearls and tips from the session, but that you'll find a way to deliver and act on this information in a meaningful way for your teams in your centers. It is now my pleasure to turn the floor over to Leanne to begin today's presentation.
Thank you, Carrie, for that introduction, and hello and welcome, colleagues, to the Becker's webinar on taking a close look at your infection control plan to ensure regulatory and accreditation compliance with the CMS Infection Control Conditions for Coverage 416.51. This presentation is not only for surgery center infection control coordinators, but also for administrators, clinical leaders, employee health nurses, facility safety coordinators, quality coordinators, and your medical leadership. This presentation also contains numerous slides, and in essence of time, several of them are screenshots to web pages and resources that I will just quickly share, then we'll move on. My intent is that you will be able to retrieve this information in greater depth as you wish after the presentation. And again, in this brief 1 hour, my goal is to provide you an overview of what is expected by regulatory and accreditation surveyors regarding your infection control plan with some built-in additional detail for your reference and action after this webinar. So on to slide 2. Here are the 5 objectives as stated. Describe the components of the infection control plan, examine internal and external reporting requirements for the ambulatory surgery center related to your plan, discuss the role and responsibilities of the infection nurse preventionist, or ICP, that I will reference throughout this presentation, identify top infection control focus areas during regulatory and accreditation surveys, and a very important one as we wrap up, implement one new idea and action to support your center's infection control plan with your team. So you may wish to also jot down some notes and questions as they come to mind. I would like to request that in essence of time and for this call and in consideration of all the many participants on today's program, which at this time there's over 500 who have called in, which I'm thrilled about that today. If you have any questions that are so very specific to your infection control plan or for your infection control coordinator or related to any equipment or supplies that you use, please feel free to contact me directly and I'll be happy to offer you my full assistance. So on slide 3, as you will recall, the 2009 release of the CMS Conditions for Coverage that we all have been quite familiar with over the past many years, we've also learned that a majority of surveyor activity and even citations have and continue to be related to this infection control condition, 416.51, which contains 2 separate standards. The first standard is on the sanitary environment, 416.51a, And this program today will address the second standard only, the Infection Control Program 416.51b, which states that your plan must include documentation and evidence that the ASC has considered, selected, and implemented nationally recognized infection control guidelines, and the program must be directed by a designated and qualified professional who has infection control training and education. So on to slide 4 and objective 1, which is to describe the components of the infection control program. On to slide 5, and in order to support the objectives, I've laid out the foundation of the infection control plan in 10 key components as listed. So in the following slides, I will provide some information related to each of these 10 key components that you can consider as you explore the details of your own infection control plan to ensure compliance with the conditions for coverage regulation as well as accreditation standards. You may find it helpful to have a copy of your infection control plan handy to reference during this presentation as well. On to slide 6, I present the first component of the plan, and that is your plan must include a purpose statement identifying that your plan is based on guidelines and recommended practices from leading authorities and experts in infection control. And as you can see here, there are some primary authorities and experts listed for you, such as CDC, APIC, AORN, SGNA, the International Association of Healthcare Central Service Materials Management, or ISHM, and others. So let's take a moment and think about this information as the first key component of your program. What a surveyor will likely ask is that you provide evidence or give an example of practices that you have in place that are based on guidelines from leading authorities in infection control that you can share or that you can demonstrate that you do follow, such as the CDC's hand hygiene guidelines. And for the GI setting, for example, that you have in place high-level disinfection protocols established by SGNA and others, and for processing semi-critical devices and equipment like you would do for your GI endoscope. You also practice sterile technique and have infection prevention processes in place for protecting patients from risks of postoperative surgical site infection. You accomplish this by performing many infection prevention activities such as maintaining a sterile field and wearing surgical attire, which happen to be guidelines and recommended practices by AORN, APIC, and the CDC. So look around you and see those steps and actions you take every day, which seem very basic, and what you do every day that are really based on guidelines from leading authorities in infection control. Now on to slide 7, and the second element of the plan should be based on the regulatory and accreditation requirements that your facility's governing body must approve, oversee, and fully support your infection control plan and all related activities. You also may have your MEC involved with this, your Medical Executives Committee, that is, involved with the process. So your MEC and or your governing body must review the plan at least annually, and whenever there are any changes that would require their guidance and input. Any reviews also must be reflected in your meeting minutes, so this is the documentation evidence that surveyors will look for when they visit your facility. You likely have your processes well established for your program to be presented to your quality committee by your ICP. Then this information is forwarded and shared on with your MEC and governing body according to your facility bylaws for recommendations, actions, and approval. Now on to slide 8, and as a third component of your plan, you will see that regulatory and accreditation surveys expect that your governing body with your medical leadership has designated a professional to serve as your facility infection control nurse, preventionist, or ICP, and there must be documentation of authority present in that person's personnel file. The recognition and assignment of authority delegates that the ICP will manage the center's infection control plan and all related responsibilities as granted and fully supported by the GB. Your GB and facility leadership must fully support the activities under the guidance of the ICP in your center and provide time and resources to support your ICP to perform their role and responsibilities. This document should be reviewed at least annually during performance appraisal time and also implemented whenever a new ICP steps into the role. I provided for you an example of an authority statement that I use and is established by the governing body to acknowledge your center's ICP. If you don't have an authority statement document similar to this one, feel free to use something like this. On slide 9, the fourth element of the infection control plan establishes that there must be clearly identified goals that tie to the organization's mission and values and practice setting. The plan must also allow flexibility in infection control activities in order to respond to various infection risks and events, such as when there's a community outbreak of a transmissible condition or during anticipated times of the year when there is typically an increase in transmissible conditions such as during flu season. Your program's goals must be periodically reviewed to ensure appropriate strategies for infection prevention are clearly in place and fully support a thorough communication and education plan for everyone in your facility. This is for all healthcare workers, including physicians, contractors, and vendors. Your program goals must include clear and actionable strategies for reducing infection risks. And like we reviewed in the first few slides, you're performing many actions and tests that are already very well-known clear strategies for reducing the risk of infection in your patients as well as your fellow healthcare workers. On slide 10, the fifth component of your plan requires your program to have a defined scope, which covers who you serve, what actions you have in place to serve the identified population, and how you're going to serve that population. Your population is not only your patients, but all healthcare workers in your facility as well. On to slide 11. The sixth component of your plan requires clear, consistent, and thorough investigation and surveillance processes to be in place to retrieve infection information and to search and investigate events in order to identify and trend the root causes. You'd like to have these processes clearly in place to identify, collect, and trend infection events and identify root causes in your facility, primarily through written and verbal communication with your physicians and through your post-operative patient phone call processes. So in your investigations of reported infections, it's critical to communicate to your physicians the importance of obtaining cultures whenever possible to understand the pathogen sources. What organisms are revealed from cultures will likely assist in identifying the sources of infection. And I know this is a big area of challenge in a lot of our settings. On slide 12, this slide covers your seventh component of your plan that should address risks and risk assessments and those measures through an infection control risk assessment, what I call an ICRA. So conducting an ICRA can help you identify your center's risk requiring and transmitting infections, and of importance, the ICRA can help you to identify the population you serve in your community and the impact of your demographics and location. So here's where you can further identify and explore external and internal infection risk factors and related risk mitigation strategies to support a successful program. Now on slide 13, in continuing the seventh element of your plan, so in my experience, I've learned that we've not always conducted a thorough ICRA. So I've provided some questions for you to consider in conducting your own center-specific ICRA, such as what type of patients do you serve, and what type of health concerns exist in the community and out of your patient population that you serve, who are at increased risk for developing a postoperative infection. On slide 14, furthermore, you can see that once risks are identified, you will need to prioritize them. Then you'll need to establish clear and meaningful goals and objectives for establishing prevention and mitigation strategies. And to help you with developing and implementing meaningful strategies, there are plenty of resources you can access, including the CDC and OSHA and APIC and ARN and many others. On slide 15, this slide provides guidance on the eighth component of your plan, and that's to implement those identified and developed infection control strategies to reduce your infection risks that you have established in your ICRA. These strategies should include standard transmission and bloodborne precautions as well as a well-executed hand hygiene program and a robust education plan for your center team that's tailored to your patient population and the types of procedures and services you provide. A suggestion would be just to list out those key strategies directly into your infection control plan document. On to slide 16, continuing with this eighth component of your plan, your strategies to mitigate infection risk should include collaboration with other members of your center's team as well, such as your safety coordinator, regarding your environment of care. Here's a perfect opportunity for you to tap into resources from industry experts such as OSHA, the CDC, ARN, and others, including your state and federal authorities and your accrediting bodies who support many of these risk mitigation activities. I have personally even tapped into our own local OSHA office who have come to my surgery center. The team has come to my surgery center, and they presented an in-service on the CDC's bloodborne pathogen standard and practices. And just on a note, this did not spark an unannounced OSHA visit, but was fully educational and informative and provided great value to our team. So there's another example of a great resource you may wish to tap into. On slide 17, additional strategies in the 8th element of your plan must address numerous infection control and prevention-related policies and procedures, such as those listed here, that are related to patient and healthcare worker health and safety. Slide 18 covers your 9th component of your infection control plan, and that is your education and training plan, which should include not only your patients, but your staff, credentialed providers, vendors, contractors, and others as indicated. They all need to have knowledge and understanding of a foundation of infection control best practices that you follow in your setting to reduce infection risks and promote safe outcomes. A suggestion for maintaining record keeping for infection control education and training is for the ICP to keep a journal or log of specific IC training programs for evidence of a track record of training and then to document the same for your staff. So if you look at slide 19, I provided for you an example of a training log that the ICP can use to document ongoing IC education and training. If you don't have a tracking log for the ICP education and training, feel free to use something like this as an example. So on to slide 20, and our next objective, which is actually the 10th element of your IC plan, your reporting requirements, which surveyors will definitely expect to see in place as well. On slide 21, this 10th and final component of your plan establishes reporting processes to be in place to retrieve, research, and investigate infection information and events in order to identify those root causes and trends. In the first place, to report infection events and other information is to your center's management for timely action as necessary. Then this information must be reported to your quality committee, then on to your MAC and GB for review, recommendations, and actions as indicated. I realize you'd likely have such communication processes in place in your center to report internally and then externally to designated local and or state health authorities, including the recent mandatory reporting to the NHSN, which, by the way, that reporting deadline now has been extended to September 30th. On slide 22, I provided a screenshot of the NSHN webpage that I believe you all have significant involvement with in accomplishing your mandatory reporting requirements for influenza vaccination coverage. Slide 23 shows the newer lookup tools so you can see for yourself that your mandatory measures report ASC 8 was successfully received. I've also provided the link for you. You can click on the web link and just enter your CMS certification number, which is your CCN number, to locate your report information. If you don't know your CCN number, you can enter your facility's national provider number, or NPI, and get to the report information that way as well. Aside from this, there's also a quality net lookup tool, so you can verify that your mandatory measures were reported successfully, and I've included that information and web links in the resources section near the end of the slide deck for you. On slide 24, this slide provides an illustration of what your influenza vaccination summary report looks like. And once you access and obtain this, I recommend that you keep it with your other infection control reporting data as a component of your infection control plan documentation. Slide 25 provides some instructional detail on reporting ASC 8, this measure, including intent to assess the percentage of healthcare providers immunized, the healthcare workers to be captured in the report, and the data collection time frame of October 1 through March 31st. Well, not surprising due to the significant challenges with ASCs getting through the registration and reporting procedures, and I've been there myself. The NHSN has extended the deadline even further to September 30th, as I've already stated. Even as of mid-July, there were accounts of ASCs not even registered or who did not realize they had not completed the entire registration process, and or those who had not completed the reporting steps at that time. So on to slide 26. This slide provides an overview of the infection control measures and reporting requirements. The infection control claims-based measure is ASC 5, which is the prophylactic antibiotic timing that's pulled from your claims and submitted for your quality net reporting. You don't have to actually report that directly, but you do have to report ASC 8, which is the web-based process measure, to the NHSN. On to slide 27, we come to our next objective, which is to discuss the responsibilities of the infection control nurse preventionist or your ICP. On slide 28, we have touched on several areas within this objective earlier in the presentation, so I wish to just reinforce that the governing body, which has oversight over all of your plans, must approve the designated employee to serve as the ICP, who's to have oversight over your center's plans and related activities. The ICP must have documentation of a job description and competencies specific to the role and responsibilities of the infection control nurse, and must be in his or her employee file that covers all of this information. There must be documentation of education and training completed by the ICP, which, by the way, you don't have to necessarily keep in the employee's file, but within your center's education and training documentation. It's important that the ICP seek guidance from leading authorities in infection control to stay abreast of infection control best practices as a part of the job description and the role and responsibilities. At this time, there is no requirement for the ICP to complete any specific infection control training, although there are some great training programs offered by AORN and APIC and others. However, it's important to complete training that is pertinent to your practice setting, and a surveyor will likely look to see that the training is pertinent and that it is ongoing and not just a one-time event. Okay, slide 29 provides a list of some of the more prominent leading infection control authorities that you can reference to support your ICP and staff education and training program, and I'm sure you've tapped into many of these. They provide great resources. Slide 30 shows one excellent resource that I standardly access, and it's also available to all of you. Simply register to receive timely email updates and news in the healthcare industry, including infection control articles and resources from the Becker's Infection Control and Clinical Quality webpage. Slide 31 offers yet another great resource for the ICP and team in infection control education from 3M, and I provided the web link for you as well, and this resource is also free to the registered subscriber. Slide 32 provides more IC resources with the web links provided for you, and I also reference quite a bit in my ongoing education and training for me, as well as for the surgery centers that I serve. On slide 33, in addition to education and training requirements for the ICP, we must understand that the ICP has other responsibilities that include conducting ongoing evaluations of the plan, typically on at least an annual basis, directing your center's IC plan activities, completing audits and surveillance activities, risk assessments, investigations for reported events, and more. Then, as already shared, the ICP must report this information to the facility leadership via the quality committee, the MEC, and GB accordingly. On slide 34, I provided you with a summary list of an orderly reporting sequence of activities and related documents, which are primary responsibilities for the ICP to complete in managing surveillance, investigations, and reporting processes in your center. And I'm sure you have all of this in place already. On slide 35, in completing an investigation of a reported infection, the ICP should follow a systematic process and should document all investigation activities and findings in appropriate detail on an infection control report. Once the ICP receives notice of a patient post-op infection, the first place to start is to investigate the patient's medical records and assess processes of care provided by the center, as well as the patient's history and physical, to identify any causative factors. From this, the ICP should further assess and document for trends in care with the staff, the room, the procedure type, related procedural activities, including processing and sterilization, and the physician, and have discussions with the physician and the center team throughout the investigation. The ICP then must report findings to the facility leadership in a timely manner for action, then on to the quality committee and the MEC and GB for additional reviews and actions as indicated. So now on to slide 36, we come to the fourth objective to review the top IC focus areas during survey. On slide 37, you'll likely recall the history of the survey process going back to 2009 that led to the implementation of the CMS Infection Control Worksheet, which is used by multiple surveying entities, both regulatory and accrediting bodies. And this worksheet has been updated several times over the years, with the most recent in June of this year. And on slide 38, I've provided a glimpse of the most current and available IC worksheet along with the links for your quick reference. That would be on slide 38. Thank you. So moving on to slide 39, I'm sure that you have gone through an accreditation and regulatory survey, and that these areas were of significant focus by surveyors, and they continue to be. Achieving and maintaining regulatory compliance related to these 5 areas is still challenging for ASCs. I've seen that on an ongoing basis, and due to multiple reasons, primarily variations in processes and knowledge levels of providers. Consider your hand hygiene program, for example, and areas of potential risk for noncompliance with the standard if you don't have enough of the right hand hygiene products located in the right place at the right time for most convenient access by the providers. Citations have been issued around safe injection practices with medication preparations and labeling, with the placement of multiple pharmaceuticals in direct patient care areas. And this is what I've seen. Citations were received because centers had multiples of medication vials and other pharmaceuticals and related supplies intended for more than one patient kept on carts, shelves, and tables directly within patient care areas in pre-op and PACU and in the OR and the procedure room. The expectation is that only the medications and related supplies used for administration to one patient at a time should be out, and all others securely stored and contained to prevent unauthorized access and potential contamination. Other areas where we continue to see citations are with the multiple uses of single-use devices, such as single-use blood pressure cuffs or extremity compression devices. Citations have been issued involving transportation of contaminated items to the decontamination area, not in contained receptacles with fully closing lids, as this could pose a risk for environmental contamination during the transport process. Citations have been issued for skipping steps in pre-cleaning and processing of devices that are clearly documented by the device manufacturer's instructions for use, or IFU. Maintaining a sanitary workplace gets a lot of attention as well from surveyors as they look for specific guidance documents to support appropriate cleaning of the environment, and they've identified that healthcare workers are not following the manufacturer's IFU on the product label, as well as not following their own established policies and procedures in maintaining a sanitary work environment. Point-of-care devices, especially glucometers, have also been challenging. Healthcare workers have not been able to produce the instructions for use for the devices, including producing documentation upon surveyor request that these devices are intended to be used on more than one patient within a healthcare practice setting. Surveyors will look for evidence on the manufacturer's manual located near or with the device and will observe if providers are following the documented IFUs in cleaning and processing. I've had personal experience with receiving citations in these areas, so really have given dedicated attention in ensuring staff education and training and related documentation is clearly in place to assure compliance in these areas. Furthermore, all of these areas are addressed in the CMS Infection Control Worksheet, not surprisingly so. So have you completed this Infection Control Worksheet in your setting? And if so, what did you learn? Did you identify some areas of potential risk of noncompliance or opportunities for improvement? I've learned of a few accounts where citations were issued because of the laryngoscope blades and the crash cart were uncovered, unwrapped in the top drawer, with lack of documentation from the manufacturer on how to process and store these items. Investigation with device manufacturers have revealed how to process these blades and keep them protected in storage. Some manufacturers and device model numbers provide guidelines on cleaning, high-level disinfection, and even sterilization steps for parts or all of the blade systems. So if you have laryngoscopes in your crash cart and your anesthesia cart, do you know what your device manufacturer's documentation guides on how to process and store them for safe patient use? You may want to look into that if you don't have that in place already. So on to slide 40. Surveyors will also look at these types of training topics for the ICP, as well as education and training materials provided to your staff, and will expect that the material to be pertinent to your setting. For example, if you perform GI services, resources and education material in place by SG&A and other leading authorities in GI services are highly recommended. So you can revisit your education and training materials to ensure these topics are in place as necessary pertinent for your setting. And now on to slide 41, and the last objective is really your time to take it home and assess if your plan is infection control survey ready. On slide 42, I provided a summary checklist of recommended actions that you can take in regard to your infection control program. The ICP should review and communicate your plan and policies to all in your organization, and ensure the ICP has the authority statement, the job description, and the competencies clearly in place, that investigation and surveillance processes are in order, as well as completion of the pertinent infection control risk assessments and reports that will aid in establishing meaningful goals and strategies for an effective and successful infection control program. It's important that the ICP completes and reports all the activities to your facility leadership, to your quality committee, and your MEC and GB. You can implement at least one meaningful action from this information presented today, I hope you can, that can have a positive impact on your infection control program. You may need to just review your current plan to ensure that all these areas are specifically in place. So on to slide 43, in wrapping up, I provided the web links and resources that you can access for your mandatory measures reporting requirements, as I earlier discussed. And then on slide 44, I provided additional detail for your mandatory reporting guidelines for the influenza vaccination among healthcare workers in your centers. And remember to refer to the multiple recommendations and resources and web links that I provided throughout this presentation to support a successful and meaningful infection control program that will help to maintain compliance with the infection control and prevention standards and regulations. So on the very last slide, this slide 45 is all my contact information. So if you'd like to reach out to me directly for any questions or additional feedback, I would really greatly appreciate that. We're all in this together, and we're learning together, and I value your input, and I appreciate learning of your experiences and successes as well. I hope that you identified some pearls and tips today, and at least one new action to be reinforcing to support your current infection control program and activities. And remember, infection control is everyone's responsibility. So now I'll hand it back to you, Carrie, so we can conclude with some Q&A in our remaining time together.
Very informative, and for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A, and we will follow up on questions they do not have the opportunity to address. All right, the first question we have here is the implementation of a commercially available dehumidifying/ventilated endoscope cabinet a recommendation or a requirement? Is an alternative acceptable? A metal cabinet with endoscope hangers, some ventilation, and a desiccant pouch?
I believe I'm understanding the question to look for an alternative for safe and successful storage of endoscopes.
Yes.
I can't see the questions appearing on the screen in the section for me to view, so I believe that's what that is about. And there are multiple storage solutions on the market. And the fact that they be safely contained after they're appropriately processed is key. The recommendation is that they are not out and open, and I do understand that there are some cabinets on the market that have an internal ventilation type system. So it's really going to be up to what works for your facility and some recommendations from endoscope experts. So that is really where I would guide on that, and I do appreciate that technology and the advantage to having such technology in doing that. So I hope that helps with that.
Thank you, Leanne. Next question we have here. What are the top 3 things a surveyor would look for during a visit?
Regarding infection control, the top 3 things? Well,
yes,
let's just start at my favorite, hand hygiene. Because once they see hand hygiene very well implemented and in place, other things seem to fit very well in place. They're also going to use that infection control worksheet. And in my experience doing many surveys and a lot of mock surveys, going through that worksheet with the infection control nurse or the ICP and having that time to detail that out has been very helpful. And every one of the surveys that I've been involved with in the past 5 years, the surveyors have given great attention to that and answering those questions on there and working directly with the team to answer those questions and make sure that the surveyor has everything appropriately documented. They will take that worksheet back with them as part of their surveyor assessment. There's key questions on that survey worksheet that will guide them to certain areas of practice in your setting. Not only did I say hand hygiene, but if you will reference the earlier slide that listed the top areas of survey focus, I can tell you that just doing that, they will go and look at how you process instruments, depending on your setting. If you're in a GI setting, they will look carefully at the pre-cleaning processes that start directly in the room. Then they will likely follow that provider with the contaminated endoscope directly into the processing area. They will look to see that the endoscope is clearly covered and protected and contained in a way that it does not risk contamination to the environment. The same with surgical instrumentation. Transporting contaminated instruments and items from the operating room or procedure room, they will look for those items to be fully contained and to prevent the risk of environmental contamination. I see that a lot. So also looking at cleaning the environment, the terminal cleaning processes, not only do they want to see documentation of that, they will want to see it in action and they will observe a room turnover after a case. So be cognizant of those best practices, which are supported through AORN and APIC, and they provide really good details for turnover room process cleaning as well as terminal cleaning. And the policies and procedures that we use in our surgery centers, they do detail out and differentiate who has what tasks for terminal cleaning and regular turnover cleaning. And even if you have a contracted housekeeping agency, you will want to make sure that all of that documentation is very, very clearly outlined in writing. And I typically keep a list of the cleaning responsibilities and the actions in the contract file of the housekeeping contractors. So those are just some areas that I've seen and have had experience with surveyors digging into. Regarding safe injection practices, that's a big area as well. They're going to watch medication preparation. They're going to look for designated places that they call the clean zone, for if you're preparing medications in pre-op or PACU and even in the operating room procedure room. They want to ensure that those areas are clean and appropriately disinfected and decontaminated as you prepare your medications. When you draw up medications, you all are very familiar with the 1 needle, 1 syringe, 1 time program, and they're really following that as well. So those are just some of the top areas for specific activities that I've seen in surveyor activity, as well as I will also add to the point of care devices, like I brought up in the presentation. A good suggestion is to have that point of care device or that glucometer instructions for use, their manual, directly with the device, and ensure that everyone understands exactly how to clean the glucometer and that there are competencies in place. And what I have implemented and what I've seen surveyors ask for is an evidence of some type of quiz or test in using the glucometer as well as a competency checklist. So we've developed what we call a waived test competency checklist. And if anybody's interested in seeing that, I'll be happy to share that with you. So I hope that goes over some of those main focus areas in a little bit more detail as we presented. That was a great question. I appreciate that.
Thank you, Leanne. The next question we have here, related to injection practices, I know that it is unacceptable to draw out multi-dose vials in patient care areas. However, is it okay to draw out single-dose vials in a patient room?
Absolutely it is, and there's a lot of controversy. And I will tell you, I see a lot of surveyor subjectivity out there about multi-dose vials, and we can have an entire hour conversation about that. However, for single-dose vials, like I presented earlier, the expectation is all pharmaceuticals, single-dose and multi-dose, should only be, and those related supplies, should be the only items out to be administered, prepared and administered to a patient at a time. All other pharmaceuticals need to be stored away and contained. And here's an example that we implemented in one of our surgery centers, well, several of the surgery centers I serve, that seemed to be very successful, and it was easy for the staff to manage, especially in the pain management rooms where you have multiples of medications that you use and draw quickly. We implemented a nice small tub with a lid, and we packed all of the vials of medications into that tub, and we placed the tub directly into the procedure room. And during patient turnover, after performing hand hygiene and cleaning the room, the staff will go to the tub or the little, sometimes they're a small closable cabinet, and they will retrieve only the supplies, the needles, the syringes, and the single-dose vials that they need at a time, and then they'll have those out and they'll keep everything else contained. Now, I know you use multi-dose vials, so the expectation is that those multi-dose vials would be treated as single-dose vials. I have seen that. I've also seen that multi-dose vials, if they were treated accordingly and appropriately using a aseptic technique and ensuring that the contents of the vial has not been compromised or contaminated, that's showing a very clear process. I have had experience at a surveyor fully accepting that. So I would recommend that you just seek your pharmacy expert. I'm sure you have pharmacy consultants. Seek guidance from your pharmacy consultant on that, because your pharmacy consultant understands these guidelines, as these are stated through the USP 797 Pharmacopoeia. And the APIC has also issued a very great document supporting how to manage multi-dose vials and single-dose vials. So you can certainly reference that, and if you would like that document from APIC, I certainly can guide you to that. But I'll bet that your pharmacy consultant already knows about that, and so I would recommend that you seek guidance from them in that area, because there, as I said, there are a lot of variabilities and surveyor subjectivity in handling multi-dose vials in the setting, and the expectation on the infection control worksheet guides to that question. So just be cognizant that there are some variations in that process that could be challenging at best. So I'm not in a position to tell you that it is okay or not okay to treat multi-dose vials as single-dose vials, but I would certainly encourage you to look at your manufacturer's recommendations for use and ensure that if it's a multi-dose vial, that you are using it and handling it according to the manufacturer's guidelines, and that you seek expert guidance from your pharmacy consultant.
Great, thank you. Next question I have here. Can you expound on what specifically was looked at for infection control for point-of-care devices?
Yes, I covered that a bit already. So I'm using the glucometer, because that seems to be the most common sought-after point-of-care device. And here is an example. For example, I'm just going to describe what I would consider a best practice in handling a glucometer. First of all, the glucometer, they want to make sure that your lancets are not being reused, and we all understand that the best practice is that those are single-use devices, those lancets. So when you take a glucometer to the patient bedside, you would make sure that it is clean, and you may clean it after use at the patient bedside and then put it up for storage. So that's a typical process. You get your glucometer and all of your supplies, you perform hand hygiene, and you put on gloves. Then you get your sampling using a septic technique, and you take your sampling to be tested, and then you would complete your appropriate cleaning practices. So that's what a surveyor wants to see. Then a surveyor will ask you this: how do you know how to clean that glucometer? And simply showing them the guidelines in the glucometer manufacturer's manual, which you can likely download. And I've contacted multiple glucometer manufacturers to get their manual, and I found it simply online. And I was very pleased to find out that some of these glucometer manufacturers actually have a little quiz that goes along with this glucometer. So you may want to just check into your glucometer manufacturer and see if they have that those resources readily available for you instead of you having to create all of that yourself. Then they would like to see that demonstration. A surveyor will likely watch you prepare the sampling and cleaning processes. They will also likely to see that you have a competency, a wave testing competency in place, and a competency checklist. So they're going to look for documentation of education and training on the device, and then they're going to look for observation and demonstration. That's been my experience, and I'm sure that many of you have gone through that as well. Again, I do have some resources that if you would be interested in seeing, I'd be happy to send to you. I hope that helps answer that.
Yes, definitely. Next question we have here. Are you suggesting we print copies of our ASC 5 and 8 results and keep them with our infection control logs?
I would recommend that since a surveyor is going to see that you have completed your mandatory reporting requirements, that you keep that ASC 8 document, just keep it with your regular infection control report, because this is mandatory. This is a mandatory measure. That report is a one-pager, and it's readily available, and it's one time a year. So I would consider it a relatively simple process just to hang on to that and keep that with your annual report and assessment. As a surveyor, I would look for that as well, because I would go in and ask, have you completed your mandatory measures in infection control? And absolutely yes. So it's a suggestion, a recommendation that you hang on to that report as well.
Wonderful. Next question. Does a code cart need to be covered? One surveyor indicated it should be, but the cover is then presenting with dust.
It absolutely does, and it's a dust magnet. So if you are covering your crash cart, which is not a bad idea at all, then you're going to have to come up with some process to change the cover. It's like a lot of items that have dust covers on them. Sometimes we overlook the dust cover process, and I've seen dusty dust covers. However, it may be easy to just come up with a routine, like once a month or twice a month, or if you're prone to have a lot of dust in certain areas where you pour the crash cart, you may need to change it frequently. But dust is one area that can get us in trouble. So that's a great question, and I would just come up with some practical use for dust covers and garbage bags, because they do serve a purpose. It doesn't mean that you are exempt from cleaning the crash cart, though, because that doesn't mean that it's airtight. So consider those points as well. Good question.
Great. Next question here. If a patient has a history of MRSA and the wound site is closed, would you require any old cultures?
The cultures would have to be physician ordered, first of all. However, if you are wanting to get clearance cultures, or find out, a recommendation is to get a clearance from the physician that it is okay to proceed with care. If it is an active MRSA infection, then you have certain things that you would want to ensure in place, which you already do. Think about what you're doing every day to prevent transmission and to you, to the environment, and to other patients. You're already implementing very thorough contact precautions. So, however, but being an active infection adds risk. An active MRSA infection or a patient being treated in your facility could mean that the patient is already at risk for developing a secondary wound infection. So many patients are carriers, and actually many healthcare workers are carriers of MRSA and are asymptomatic. So because we can't screen everybody every time, every day, if they are carriers of MRSA, there's key things that you should do to make sure that your patient and your environment and your personnel are safe, and that is asking the right type of infection history questions to your patients. So I value that question and know that it comes with those challenges, but if a patient comes in with an active, any kind of infection, it's a good idea to revisit that and see, based on the patient's condition, based on what's going on with the patient and where the infection exists, it may be something for the physicians to consider either postponing or treating the patient preoperatively with antibiotics a different way. There are several things to consider, and it's on a case-by-case, patient-by-patient basis. I hope that helps answer that, and I will give you an example of an active MRSA case that presented to one of my surgery centers, and we ended up postponing the procedure. There was a patient who came in for removal of a nasal septal button. It was a nasal septal implant, and of course, the nares are primary for hosting all kinds of germs, including staph. And when the patient presented to have the nasal septal button removed in surgery, the ENT surgeon did not know that the patient had a history of MRSA. And upon admission and full evaluation of the patient said, "I don't have a fever or anything, but I have been treated for active MRSA over the past 3 weeks." So the physician was notified. The physician examined the patient, and the physician said, "I do believe we need to wait. We need to wait till you finish your course of antibiotics, and I'm going to notify your primary infection control physician, and we will make sure that you're managed appropriately, and then we will continue on with your treatment." So there's an example of what we see in a lot of our settings because we have the challenges of preoperative phone calls and not getting all the information we need through the patient assessment processes. So when these patients present, the screening process really takes place because you have your patient right there. So that was just one example of a patient presenting who actually was undergoing treatment for active MRSA, and the patient didn't know that the patient could have been at risk for having further complications, as well as perhaps adding some risk to the environment and to other healthcare workers. We didn't even know if the patient was truly active, if the antibiotics had time to be fully effective yet, but the patient did say that they had not finished their full course of antibiotic therapy. So we believe that in interest of the safety of the patient and all involved in the care of that patient, that we did the right thing. So I hope that gives you an example of facing the challenges of these patients coming in who do have infections. Now, if they're carriers, we already know that we can take care of carrier patients. We have to, first of all, get clearance from the physician, and that may also include an infection control physician expert. Make sure that the entire team knows, and that we are using appropriate precautions, such as all of the standard precautions that we have in place and contact precautions that we have in place to protect the patient, the staff, and the environment. So with that, that was a great question, and I appreciate that. So I'm in essence of time, and I can't see all the questions coming through. Emma and Carrie, I'm so sorry, but we have enough for a few more questions, I see.
Yes, definitely. We have a few more minutes here. The next question we have coming in, what areas of any facility should be audited monthly?
That is a great question. Okay. So with that, what we have done in our surgery centers, we established what we call infection control grand rounds. And we have looked at, using our infection control program, we've listed out those key areas that we need to go and assess. And this is where I have actually implemented a great process to share this responsibility among the entire team, including surgical technologists and all the other clinicians on the team. For example, we have a 2-page infection control grand rounds document, and we will have a pre-op and PACU nurse go and assess the OR and instrument processing areas. We'll have an operating room nurse come and assess pre-op and PACU areas. And these areas are listed out, and actually I have used the infection control worksheet, the CMS infection control worksheet, to establish those areas to assess. And guess what is on there? Hand hygiene. So we call it the secret shopper experience. And staff members will go through the facility and assess certain areas. And we try to do that within that month's time period. And then the outcomes of that report or checklist are reported to center management as well as to the quality council by the infection control preventionist or ICP, and then we learn if we need to take actions that way. I hope that helped answer and discuss that.
Great, thank you. We have time for another question here. What risk assessments do you recommend be done yearly, for instance, TB risk?
Perfect question. And, well, this probably is a great segue that I do have another presentation on how to conduct an infection control risk assessment. But I will tell you that typically a good idea would be to implement it. I look at it as part of your infection control program review. And what we do in our settings is we do an annual infection control program review. And I call it the infection control annual report. Once a year is what I typically do is I complete an infection control risk assessment, and I include the risk assessment findings with my annual report, and then I will present that one time a year to the Quality Council and the MEC and the governing body. Findings from that is where we send the request for action to the NEC and governing body for them to participate and to make those recommendations. So those are some areas on how we can address those things and then conduct a risk assessment. But I would also recommend that when you look at your internal risk factors, which actually can tie into the infection control worksheet as well as using your infection control grand rounds type of assessment, that you seek your infection control information in your community through your local health department and your state health authority. You can probably Google your state health authority and see your TB risk assessment profiles and other prevalence of other transmissible conditions directly on those sites. What I have done in the past is I will print out reports that are state-specific on diseases, prevalence of diseases like TB, and so that I will know what's going on in the state. And then further, a lot of these reports have community and county prevalence. So you can certainly seek that way as well. So reach out to your local health authorities and your state health authorities. They provide perfect information for you to use in completing your risk assessment.
I want to again thank Leanne for her excellent presentation and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.